Good morning. This is Dr. Babak Larian here for another session of live question and answers for hyperparathyroidism. This awful disease that can affect every aspect of your existence. Anyways, we have a whole list of questions that I'm going to go through and try to answer as many things as I can. And you guys are, once you're on and you're come up with any questions, you're welcome to type it in, and if I get a chance to get to it, I will definitely try my very best to answer any questions that come up as well. But before I start this thing, I'm just going to let you know that I went to a longevity conference this past weekend, a 3-day conference. All of it focused on longevity and health and how to be healthy. And the focus of this whole thing was essentially mitochondrial health, right? And mitochondria is the engine of your cells and how it functions, right? And how well it functions and how we can optimize it and so on. And it was fascinating because it looked at disease on a cellular level rather than an organ level, and how you can keep your cells healthy, therefore the organ will function healthy, which makes sense. And how the approach to healthcare is more disease-based rather than cellular-based. And by that I mean, how can you keep your cells as healthy as possible so that your organs will function as well as possible so that you will live a healthy life. And all of that is based on what you put in it, what you do with your body, and how you manage your existence, right? Seems very simple. And it is, but you have so many external factors that are affecting it. For example, the external factors being the food you eat and what you put into your body, right? Majority of this processed food that you eat and this narrow range of food that we eat is a problem, because evolutionarily speaking, we had a wide range. We were eating lots and lots of vegetables that were seasonally present, not the same 7 or 8 vegetables that we eat all year long, right? Because now it's always available. And that's a problem. That's a big problem. And then how much rest you get. Sleep is a massively important function, because your body needs appropriate deep sleep to detoxify itself, to reorganize itself, to get itself back into the position to give your brain a rest, to give your heart rest. And sleep problems are so common, almost ever present, right? To the point that most people who have sleep issues don't even know that they have sleep issues. So if you have a sleep problem that you know of, that your sleep is not good, or if you partners tell you that your sleep is not good, test yourself out. Figure out how to address your sleep issues. Stress management. Lifestyles in these big urban cities are very stressful, and we put ourselves in more stress, and that stress really makes our body really inefficient, because we're not designed for long-term chronic stress. We're designed for short-term bursts of stress, and so on and so forth. So since you're here and looking to get healthier as it relates to parathyroid, try to get healthier as it relates to all aspects of your life. So I'll stop preaching and move on to the first question. Annette Rivezzo. I was diagnosed with normal calcemic hyperparathyroidism in 2022. And normal calcemic hyperparathyroidism is when your calcium is in the normal range, right? But your PTH is elevated above normal, okay? And my doctor, my endocrinologist, has been following me closely since my diagnosis. My calcium has never been out of range since my diagnosis. It is often on the low end of normal, 9.1 to 9.3. I've consulted numerous doctors that are not in agreement as to whether I have normal calcemic primary hyperparathyroidism or secondary hyperparathyroidism. Dr. Ye at UCLA and Dr. Parak at Norman Center will not consider me for surgery. Dr. Ye told me that clinical studies show that people with normal calcemics often don't benefit from surgery. Dr. Parak believes that I might have secondary and wants to continue to monitor. I recently used Dr. Deva Boone's app and entered my 12 sets of labs. According to the app, 5 of my labs results indicate normal calcemic, 5 indicate secondary, and 2 are inconclusive. My most recent labs that were drawn a few weeks ago are calcium of 9.1, PTH of 104. Iron is calcium was 4.8, phosphorus 3.7, vitamin D 22, which is low. 125 vitamin D was very high at 110. Okay? So you have low normal calcium, right? And elevated PTH. What you're trying to figure out is this elevated PTH secondary to you having low calcium levels in your body, potentially from having low vitamin Ds, or is it from some other reason? The fact that you're, let's see, the fact that, all right, so the fact, in a normal parathyroid environment, right, this is the parathyroid system. In a normal parathyroid environment, when we have we have these 4 parathyroid glands that are looking at your calcium levels in your bloodstream, right? And only 1% of calcium is in your bloodstream, 98% is in your bones, right? And 1% is in tissue, muscle, nerves, so on and so forth, right? Your parathyroids only see the calcium in your bloodstream. So if the calcium in your bloodstream is low, you produce extra PTH, and extra PTH tells your bones, put more calcium out in the blood, I need more. It tells your kidney, get more calcium back from the urine. Don't let it go so easily. It also turns on an enzyme that changes inactive vitamin D. Inactive vitamin D is the one vitamin D that you test in your bloodstream to the active form, 125. This is the active form. And the active form of vitamin D goes to your intestines and increases the absorption of calcium from 20% to 80%, right? And then you have more calcium in your system. And then when your calcium is low and your PTH is doing this, calcium should come up and things should balance out, right? So if you have low vitamin D levels, right, these are low, and you're not making a lot of this, therefore you're not absorbing as much, right? But in your particular case, your calcium is low, your PTH is high, your vitamin D is low, but your 125 vitamin D is high, right? This is the one that helps your absorption. So your absorption problem is not a problem. You're getting enough calcium through your food, right? At least as it's mediated by vitamin D. Do you have a vitamin D deficiency issue that's causing it? Potentially, but let's read some more and see. Okay. So my most recent labs show calcium of low normal 91, 9.1. PTH is high at 104. Regular vitamin D is 22, which is low. Activated vitamin D is 110, which is high. So these two are low, and these two are high. Okay? Let's move on. Let's see what else we got. I've not been supplementing with vitamin D all year, so that the elevated was not due to supplementation. I'm going to share a few. Well, the elevated 125 is because your PTH is high, so you're activating more. I'm going to share a few additional labs that were taken over the past year. So November 2024, again, calcium was 9.1, PTH is slightly elevated at 72, vitamin D is 28 low, 125 is 67, upper range of normal but not abnormal. May 9.2, 89 PTH, Vitamin D is 26, 125 is 89, a little slightly higher. Why was my recent vitamin D so elevated? So the higher your PTH number, the higher this transformation and the higher will this be. So that's why your vitamin 125 is higher. Okay? So your latest numbers had the highest PTH that you've reported to me. Therefore, you have the highest activity here, and therefore the highest amount of this being produced. So that's not unusual. Okay? Question number 2. Given my vitamin D is almost at a deficiency level, should supplementation with vitamin D despite being so high? If so, how much daily vitamin D do you recommend? All right, before answering that question, I would suggest that you either do a 24-hour urine calcium or let me know what your 24-hour urine calcium is, okay? Because you don't know, I still don't know if the fact that your calcium is low, is it because your vitamin D is low, or is it because you have some sort of a malabsorption where you're not absorbing the calcium, right? So calcium has to get absorbed from your intestines into the bloodstream, right? It has to get into your blood vessels, okay? And if you have any kind of intestinal issues that prevent that, right, then it doesn't matter how much vitamin D you take, you're not going to absorb that calcium into your body, right? And the only way to know if your calcium that is in your bloodstream is appropriate or too low is by measuring the amount of calcium that your kidney is putting out, right? So the calcium that's coming out through the kidney is an issue. And so the 24-hour urine calcium will tell us that, right? Because if the amount of calcium in your blood, so the blood vessels that are coming to kidney have calcium in it, right? If the amount of calcium in your blood is too low, then the amount filtering out will be too low as well, right? So if your 24-hour urine calcium says that the amount of calcium in your urine is low, right, then you have secondary hyperparathyroidism, okay? And that's what's causing your PTH to appropriately be high, okay? If the amount of calcium in your urine is normal or high, right, then you probably have primary hyperparathyroidism. Let me tell you why. There, on the surface of the parathyroid glands, there's a calcium sensing receptor. So on the surface of every single parathyroid gland, there's this calcium sensing receptor that you see here, right? And when enough calcium is attached, there's no PTH. When there's not enough calcium attached, then you have PTH coming out, right? And so the relationship between calcium and PTH ends up being this, right? This graph, okay? So those and there's a setting for calcium. So the calcium in your particular body, in your particular cell, has a set point for a certain calcium number. This person's calcium set point is 9.5, right? For you, if your calcium set point is 9.1, let's say, that means your particular graph will look like this, where you are doing this, and your set point is here, right? Okay. And so when your calcium is lower than that, you have a higher PTH. When your calcium is higher than that, you'll have a lower PTH, okay? Now, if your calcium set point is a lower number than this, let's say your calcium set point is 8.5, right? when you reach a 9.5, your PTH number should be very low, okay? And that's a problem, right? So let's have the three scenarios. Scenario 1, Scenario 2, and Scenario 3. If your calcium set point is Scenario 3, where it's 9.5, right? And your PTH is now hovering at 9.1, then you should have a really high PTH, right? Going high numbers, because you're following this blue graph, right? And if your calcium is always constantly lower than the ideal number of 9.5 that your body desires, if you're hovering around here all the time, because your intestines aren't absorbing enough calciums, right? Then your kidney, which is also set to this 9.5 number, will recognize that. Your kidney will say, your calcium is 9.1, I shouldn't filter out extra calcium out of my urine. I should hold on to it, right? Because your body doesn't have enough calciums, right? I'm getting as much as I can with the PTH from the bone. I should also grab as much as I can from the urine, give it back to the bloodstream, okay? And so you may have a secondary hyperparathyroidism due to intestinal issues and absorption issues, okay? So the 24-hour urine calcium is going to help you with that. The calcium sensing receptor setting, the CASR setting, in a normal parathyroid is set for the same number in the kidney as it is in the parathyroid glands, right? It's the same gene in two different places, okay? So if you get a mutation in one in the parathyroid gland, and in the parathyroid, instead of being this 9.5 number is now 10.5, then you have hyperparathyroidism, primary hyperparathyroidism. But if you have a malabsorption and you're set here, right, but your calciums are hovering lower, then you're going to have overfunctioning of the parathyroid to bring this number to the number it needs to be, okay? So, Annette, I don't have adequate information to be able to give an answer to your questions. Should you be supplementing vitamin D? Yes, you should be, okay? And the reason for it is that the conversion rate between 25 hydroxy vitamin D and 125 is dramatically different. So let me show you. Okay. So when you look at the units of 25 hydroxy vitamin D, the units are 35 nanograms per milliliter. The 2.5 to 125 is picogram, 1,000 times difference, right? So 35 nanograms is equal to 35,000 picograms, right? So you have 35,000 of this that turns into 80 of that, right? So if the regular vitamin D was low and instead of 35 was 24 for you, you still have 24,000 units of material vitamin D that can turn into activated vitamin D. So even though that number is low, it's not dramatically low enough where your body just cannot function, okay? And so I think if you change this number from 24,000 to 35,000 by taking supplementation, you're not going to make this be much higher, right? That's not the problem. The problem is your PTH is too high and it's carrying on the conversion, okay? So I would supplement, I would do 2,000 units a day. I wouldn't go crazy with it, okay? But I think you need the 24-hour urine calcium. You need the labs done, calcium, PTH, the vitamin Ds, magnesium. Let's see. Let me get you normal calcemic. So you have to rule out all the other causes of high PTH, right? And all the other causes of high PTH is vitamin D deficiency, which you can correct by supplementation. You've never been able to correct it, so this is unlikely to be the problem. Check in to see if you either have low calcium intake or malabsorption, right? Which a 24-hour urine calcium is going to tell you, okay? And then with malabsorption, if you have 24-hour calcium that's low, you do tissue transglutaminase antibody to see if you have true celiac disease or actual gluten intolerance. Okay. Let's see what else you got here. What other question? Question number 3. When I've elevated 1, 2, does that mean I have vitamin D toxicity? So would we answered that? 4. Based on the labs I shared, do you suspect normal calcemic? I can't answer you because I don't have the 24-hour urine calcium. Right? Based on what you have, you can either have secondary hyperparathyroidism due to any of these causes, or you could have normal calcemic. I need more information. When a patient presents to my office with normal calcemic hyperparathyroidism, the first thing I do is go through this chart, try to see if any of these possibilities exist, if they are taking any of these medications that could influence the numbers, right? A small subset of patients actually have an intestine that's resistant to 125. We, as we get older, tend to have that. All right, so going back to this, a small subset of people are resistant to this, so they need more and more and more of the 125 active vitamin D for intestines to absorb, right? And so sometimes you have to actually give them the activated form, right, to get them really high numbers. And that's a possibility, okay? So you need a full workup. I'm not sure if you've entirely had a full workup. Although I know you're an endocrinologist at Cedars and he's really good, you may want to have a second set of eyes of someone who has parathyroid particular focus interest. Now, normal calcemic hyperparathyroidism is a problem. And the problem is that forces a lot of doctors to avoid treating them. I went to England 5-6 years ago, and I visited a very good parathyroid surgeon there who was involved with making the UK NICE guidelines. And these are the guidelines for the National Health Services to decide if they should do surgery treatment for hyperparathyroidism or not. And in looking at their whole system of numbers, they decided that anybody that has above normal calcium and hyperparathyroidism should get treatment. There should be no wait and watch, because in their system, it costs more to wait and watch by doing repeated labs and scans and as compared to doing surgery and getting it done, right? So for anyone above normal calcium levels, the UK system recommends parathyroid surgery. Right? Symptoms, no symptoms, osteoporosis, kidney stones or not, doesn't matter. If you have high calciums, hyperparathyroidism, you have surgery. And the same doctor said the UK NICE guidelines carefully avoided talking about normal calcemic hyperparathyroidism because we don't know the answers. And that's true. We don't know the answers yet. But we know some facts. We know that hyperparathyroidism is caused, right? So if you have someone who has, let me go back again. So if you have someone that has a normal setting of calcium of 9.0, and then they get a mutation in one cell that is now set for 11, this is what happens, right? The new cell goes to this. So that new cell is now set for 11. And as the calcium numbers go up, the normal graph stops and the normal cells stop producing PTH, and that abnormal cell keeps producing PTH to try to drive the calcium number to an 11, right? So there's always a starting point. So if your starting point is 9.5, right? Actually, your starting point is 9.5, and your mutation takes you to a 10.5, and your normal range is this green box, then this person has high calcium hyperparathyroidism, right? Hypercalcemic hyperparathyroidism. On the other hand, if your starting point is 8.5 and you go to 9.5, exactly 1 unit elevation, just like this one was 1 unit elevation, but you still are in the normal range, then no one's going to see that. So that's what we call normal calcemic, right? Now, if you have someone who presents with a calcium of 9.5 and PTH, let's say, is 90. Normal range is 15 to 65, right? And they're at 90, so they're higher. Okay? And both of them are the same. PTH of 90, right? Both scenarios. Okay? But you don't know what the starting point is. So if someone has a starting point that's 8.5 versus a starting point that's 9.2, they have different diseases, right? This person may not have much of an illness, and if you operate on them, they won't feel any different. This person may have lots of symptoms, and if you operate on them, they will get better. And that's really the study we need to do. We need to figure out how, we need to figure this out. We need to figure out what the calcium set point is. And that's really the revolutionary thing. If we can figure out what's the calcium set point for every individual, right? Then we can figure out how far away they are from their natural calcium numbers, and then based on that decide, this normal calcium patient should have surgery, this one, and this normal calcium patient, it's a mild change and they don't require surgery. They're okay, okay? And so that's part of the reason. We don't know what percentage of people fall into this category versus this category. And so the way I decide on this is, if you have a lot of symptoms, right? If you go through the list of parathyroid symptoms, and you have a lot of these symptoms that, let's say 5 years ago you were very athletic, you were working, you were, the president of the bank, and you're functioning really well, and everything is going well, and all of a sudden you're not feeling well, your sleep is poor, you're fatigued, you can't focus, in meetings you're kind of dazed, and you're just not as sharp as you were. You can get the job done, it just takes much more effort and time to get the same job done. You're not as motivated in your life, you're not playing with your kids as much, your libido is gone, your social interest is just not there anymore, you can't figure yourself out, all of a sudden you feel like you're old, then you should get treatment with normal calcemic. If you're still running marathons and climbing mountains and you're a triathlete and things are going well and you do put your bone density and it's healthy and you have no kidney malfunction and you have normal calcemic hyperparathyroidism, that's a patient that I think is potentially someone that can be monitored, right? And you have to look at the patient individually, and each person is different, of course, but all of that matters in this equation. Okay? So hopefully this is helpful. Annette, I think you need more stuff done. I need more information to be able to give you better advice. But good luck, my dear. I'm happy to look at your information, and if you have 24-hour urine calcium, let me know what that is, and I'll get back to your question just right now. Next question comes from Ludmila Tuevska. I'm sorry about massacring your name. I've had a renal calcium leak and since young with kidney stones and now osteoporosis. My labs show calcium around 9.9, PTH 40, and hyperplasia has been suspected. Okay. I was started on thiazide and surgery was suggested. If this is multi-gland hyperplasia, what is the likelihood that surgery improves urinary calcium, bone density, and stone risk? If you've had renal calcium leak, right? Let me go back and show you that. If you have renal calcium leak, which means you usually have normal calcium levels in the bloodstream, but your kidney is letting go of calcium, so your parathyroid glands are overworking and producing a lot of PTH. And that's causing your bones to release a lot of calcium, which causes osteoporosis. And because you have a lot of calcium in your kidney that it's leaking out, you make a lot of stones, long history of kidney stones. Treatment is hydrochlorothiazide. Ludmila, you've been taking thiazide for a while, I would say a year, and your calcium numbers in your bloodstream come up a little bit and your PTH normalizes, then I don't think you need surgery. I think you need to watch it, right? Because you're getting parathyroid hyperplasia secondarily to the calcium leaking out of your urine so much, right? So let's go back to this, right? So if your kidney is malfunctioning and letting go of too much calcium, right? All of this is coming out, right? And because it's coming out, your parathyroid, there's less calcium in your blood, okay? Then your parathyroid gland overworks, okay? And it overworks to try to get more calcium in your bloodstream, so you get osteoporosis because you get loss of calcium here, and you may have too much vitamin D activation, right, and have a lot more absorption, right? But your calcium is not, your calcium is 9.9 on the upper side of normal. Your PTH is 40, right? It looks to me that if these are the numbers that you have on the thiazide diuretic, that those are actually good numbers, right? So what I would suggest is, if you were my patient, I'd have you on the thiazide diuretic, right? I would check your labs every 3 months for a year, right? If I have improvement of your numbers, right? So if you walk into my office at first with a calcium of 9.1 and a PTH of 107, like Annette did, right? And then by doing the thiazide over a 6-month period, I bring you from a calcium of 9.1 to 9.9, and from a PTH of 107 to 40, and you're doing this now, then I don't see much of a point in doing surgery, because now your parathyroid is functioning properly. So I think you need time on thiazide to see if you have appropriate normalization. The people who need surgery after a long-term thiazide diuretic, they have what we call tertiary hyperparathyroidism, which is having secondary hyperparathyroidism for a long time, right, which causes the parathyroid glands to get bigger and bigger because they're overworking, and then at some point you get mutations in them where you get multiple adenomas within them, and they work independently and they don't care about the calcium level anymore, right? And they just overproduce. That you can't correct with thiazide, right? So if these are your numbers now, they look like to me that you've corrected things, okay? And if you've corrected these, you look at your numbers in the long term, and then you look at your bone density. So if you on thiazide diuretic are doing better, right? Your PTH is lower. You do weight-bearing exercises, and your numbers stay normal in that year. A year and a half later, you do bone density study, and you find that your bone density study gets stronger. I would definitely not do surgery on you. I would say, you no longer have secondary hyperparathyroidism. You've had a good doctor. Your thiazide is doing your job. You're great. You'll have to take thiazide for the rest of your life, but you're doing great. So that's my advice. Lala Woods, hello again. I had 3 glands removed in 2020, hyperplasia. I have struggled to maintain a decent vitamin D level. On several occasions, I've taken mega doses of vitamin D with no issues. I was put on it in August. After 4 weeks, I had random blood work done and had a low GFR of 53. Less than 60 is considered low. I've never had kidney issues. The doctor tested me a week later, no longer taking vitamin D, and GFR was 58. It is now 66. Could the large dose of D cause this? I don't know. I don't know how vitamin D is a cholesterol-based vitamin. It's fat soluble. I would think that the kidney is not the place that, I think the liver is what gets rid of vitamin D, right? I don't think it's the kidneys. I don't know if the vitamin D actually has a direct effect. I've never seen it in any of my patients. But, the reality of your metabolism and your body function is what it is, right? Now, I'm not a fan of the mega doses of vitamin D. I'm just not. I like low doses of things in the body, okay? So I would stay away from the higher doses, and I would just take low maintenance doses. I know the guidelines are that you want to get your vitamin D above 30, okay? But that may not be what your particular body needs, right? If your vitamin Ds are in your particular case, are in the 20s, right? Your calcium is normal. Your 24-hour urine calcium is normal. Your bone density is good and healthy, right? And your kidney function is now without the vitamin D in the 60s, then I would stay away from that. I would just continue to monitor rather than over treat. Okay? Now let me continue. My endo wants me back on it. Again, I have a little bit of a disagreement. I think you need more parameters than just the vitamin D number. I would like to see the 125 vitamin D as well, because if that number is normal, then you may want to just hold off. They're having me followed by a kidney doctor for sure, because it may be incidental that your numbers go up and down at the time of your vitamin D consumption. It may be that it just by chance it was that wasn't the cause, that you may have another kidney condition. So having a nephrologist on board is smart. He's not concerned, but will monitor me. My D level was 16, it came up to 29, I'm 63. Lastly, I have a sister that had one adenoma removed. I've had hyperplasia. They're going to do some other testing, by my endocrinologist does not believe this is a hereditary issue. Your thoughts? I'm suspicious, right? You know, in the U.S. we say one in 800 people get hyperparathyroidism, and 1 in 250 people over the age of 60, right? So if your sister is close to 60 as well, 1 in 250 chance that you have it, and 1 in 250 chance that she has it, right? And to put those two low statistics together at the same time and having it, there has to be either both of you are exposed to same toxins in your environment that's causing it, or you have a genetic link, or a combination of both. You have a weak genetic predisposition and some toxin exposure, and together that's what's happening. But I would do the genetic, there's no downside to genetic testing, okay? It can only help you, and specifically help your siblings and children to look into this thing if you have it. I got an answer from Annette. My 24-hour urine calcium has always been normal. Annette, if you can share the number with me, that would be helpful, because again, if your 24-hour urine calcium is normal, right, and you have a normal calcemic hyperparathyroidism, right, and not low numbers, that means your kidney thinks that the number you have, and remember, PTH goes to your kidney and tells your kidneys absorb the calcium back into the bloodstream. So you get PTH causes a decrease in your 24-hour urine calcium, high PTH. So if you have a normal 24-hour urine calcium with this high PTH of 104, right, without that PTH, at this calcium level, your 24-hour urine calcium would be even higher, right? So if you have a normal 24-hour urine calcium with a high PTH, that means your calcium level is, as it relates to your kidney, is a higher number than it should be, because your PTH is forcing the exit of, forcing the reabsorption of calcium from your urine, right? So your 24-hour urine calcium, again, is a false lower number. So if it's in the normal range, it should be a little bit higher. So having normal or high 24-hour urine calcium in the setting of normal calcemic hyperparathyroidism tells me that you actually have normal calcemic hyperparathyroidism and not secondary, right? So, and if you were my patient, again, I would go through the full workup, right? The full workup of secondary elevation of high PTH, and if these prove to be negative, then I would proceed with scans and think about doing surgery if you have a lot of symptoms, which it looks like you do. Excuse me. Going on. Sue Thomas. Hello, Dr. Larian. Hello, Sue. I've had a total parathyroidectomy and one quarter of my parathyroid gland implanted into my forearm. I have hyperplasia. My operation was completed in 2024. Recent blood work is showing PTH is 1.7 and calcium is 2.17. Corrected calcium is 2.4. I take calcitriol 0.25 micrograms a day. So you still have parathyroid hormone being produced. So you haven't shared with me your range of normal for your PTH, but I think in the UK system it's 2.5 to 6. So 1.7 is below the normal level. Okay, then you go on to say, this is the first time my calcium PTH has been enriched. However, I started getting tremors at night, and my blood work shows high cholesterol, which I'd never had before. I have just moved countries, so I've been unable to see an endocrinologist. My appointment is next April. Any advice is greatly appreciated. I think if in the labs that you have, a calcium of 2.17 is in the normal range, and a PTH of 1.7 is in the normal range, okay, I would repeat it one more time, fasting and at 8 o'clock in the morning, while being on the calcitriol, right? If they're still normal, then I would decrease the calcitriol to half of what you're taking. Then I would take another set of labs, maybe a month and a half later, excuse me. If your numbers are still in the normal range, then I would come off the calcitriol, right? Because calcitriol is for absence of PTH, right? This is what calcitriol is for, right? So if you are parathyroid hormone goes to the kidney, turns on the enzyme 1-alpha hydroxylase, which turns inactive vitamin D to calcitriol. Okay? If you don't have any PTH, if your PTH is 0, then you can't have this done. Then you're not, no matter how much of this you take in your food, egg yolks, salmon, lots of vitamin D supplements, sit in the sun, you're still not going to make this. Right? And so calcitriol is someone who doesn't make PTH. If your PTH is now in the normal range, you don't need calcitriol. That's the reasoning, right? But I wouldn't all of a sudden cut it off. I would slowly diminish it, look at your labs and see what your numbers are doing, okay? And don't do it without looking at labs, all right? Because you don't want this normal set of labs that you saw today be just a one-time event that happened and you got lucky and looked at the labs at a certain moment in a day where the numbers were normal, and then the remaining 23 hours may be abnormal. You just have to get a better idea before you make big moves. Good luck, Sue. Laura Given von Schritz. Good morning, Laura. Should I discontinue D and calcium, vitamin D and calcium supplements if current blood work is 9.5, calcium 48 PTH, and 60 vitamin D after parathyroid surgery this past August? 2 parathyroids removed, one removed years ago, and 1 left. Does 9.5 and 48 mean primary hyperparathyroidism has returned? Well, listen. You removed 1 parathyroid years ago, and then you removed 2 more now. What are the odds that you had 3 separate mutations in 3 separate glands happening at different times versus you having hyperplasia? Well, all 4 of your glands are abnormal except that this was big a long time ago, these 2 got big later, and this one is relatively normal size, but so you have an abnormal parathyroid here, right? You have hyperplasia, right? You just had asymmetric hyperplasia, right? And so this last abnormal gland is still there. Okay, so these are gone. And more than likely this is abnormal. Okay? So what are the odds that you have hyperparathyroidism? But but it depends on the degree of hyperparathyroidism you have. If you keep looking at your labs, and I would check your labs every 3 months, fasting in at 8 o'clock in the morning, making sure you're not taking any biotin, right? And if your numbers are, let's say you hover around 9.5, if your number goes from 9.5 to 9.4 and your PTH goes from 48 to 55, and then the next lab you check and your calcium goes from 9.4 to 9.7 and PTH goes down from 60 to 30, then you have a parathyroid, the one remaining last parathyroid that, although it's hyperplastic, is acting fairly normally, right? You can sit and wait and monitor it. You don't need to take action, okay? I'm taking 1,100 milligrams of calcium, 1,800 units of vitamin D, 120 of K2, 490 milligrams of magnesium, very, very exact numbers. Good, they look good. I still have muscle twitching. Heard that 9.5 calcium is not the correct, you know what, everybody's different because everybody has a different graph, right? It all depends on what your particular graph is. So let me change this. Let me find a graph that has it based on not percentage of maximum, but rather numbers. Let me see if I have that graph. Okay. So this is showing hyperparathyroidism as percent maximum. This one is as concentration, right? So this is the normal graph, right? And so if your set point for calcium is 9.0, right, and your calcium goes to 9.5, your PTHs should be very low. But if your set point is 9.5, which means your graph looks like this, right? Your PTH should be around the 40s. Okay? If your set point is a little bit higher, right? At 9.5, you should be a much higher number. So just those numbers alone and one set doesn't tell me what your situation should be. Okay? You need to look at a multiple set of numbers to see it out. Okay? I'm guessing I need to lower or stop supplements and do blood work again. I wouldn't stop the supplements. I would look at your labs on these supplements multiple times, right? Because if you're functioning properly on these supplements, then you're supporting your parathyroid and calcium systems, right? But also doing a 24-hour urine calcium. That'll tell you if you're taking too much calcium supplementation, okay? I would look at all those numbers. All right, Laura, good luck. Leslie Harris. Before Leslie, Annette Revezzo says, thank you for your input regarding a 24-hour urine calcium urine that you just mentioned in your response. I just looked at my lab. When I was first diagnosed with hyperparathyroidism, my 24-hour urine calcium test was 72. Right. At the time, my calcium was 9.2, PTH was 98. It looks like that was the only 24-hour urine calcium test. Does that give you clarity? Okay. Well, I know the reference range for your lab says 24-hour urine calcium is 35 to 250, but most of the time we consider a calcium less than a 24-hour urine calcium less than 100 to be less than normal, right? So what I would suggest is, again, go through that table of normal calcemic hyperparathyroidism workup. Do the full workup, right? If your calcium like if you repeat your 24-hour urine calcium and it's still a lower number, less than 100, I would focus in on increasing your calcium intake and seeing and vitamin D, maybe even trying calcitriol and seeing if you can lower that number. I do think you need more of a workup to figure this out. Okay, but thank you for seeing this and responding to me. All right, very good, my dear. Let me go on to Leslie Harris's question. Hey. So I had surgery in 2023, and apparently I've had a tumor for at least 15 years. Okay? I've been so tired and developed neuropathy and muscle exhaustion as a result. And it worsened after surgery. Calcium was great until my recent blood work. My last blood work shows my calcium back to 10.2, which is disappointing. Any suggestion? Can I heal from this mess? Well, Leslie, what you need to figure out is if you still have hyperparathyroidism. Right? And you can't do that by just looking at the calcium number. You need to look at both calcium, PTH, and then the vitamin D numbers. Again, fasting in at 8 o'clock in the morning, making sure you're not on any biotin supplements for at least a week prior to doing this testing, okay? Once you do that, you can see if your calcium is doing this and you just caught the calcium level at a point where it was a little high, but your PTH was really, really low, which is normal, right? If you just had some big cheese plate, and you just had a huge surge of calcium in your bloodstream, which in case your PTH should have lowered, that may be just normal, right? In which case, then, if that is the case, if you no longer have hyperparathyroidism, then you have to look up for neuropathy and muscle exhaustion elsewhere. On the other hand, if your calcium is 10.2 and your PTH is 50, 60, 70, not suppressed, high, normal, or elevated, then you have persistent hyperparathyroidism, and that's what you should address, okay? And you can figure out, now, can you heal from this mess? Yes. I have patients who have improvement in their symptoms up to 4 years after surgery. And there is this interesting thing that I've noticed, that people who have foot pain prior to surgery, a lot of times have worsening of the foot pain after surgery for a bit of time, sometimes even a year and a half before they have improvement. And so, unfortunately, the healing from hyperparathyroidism isn't that immediate from A to fantasticness immediately for most people. It's the small minority. For most people, this disease develops slowly with the calcium numbers going up over the years, right? Which is what this is showing. Right? This is showing a disease that's slowly. So the graph is slowly coming up to that, basically, in a sense, right? Or the parathyroid is slowly taking over and coming to this number, okay? And so you have years and years of going from here to here, and then you have surgery, all of a sudden you go back to that, right? And your whole body has to adjust to that. And the nerves that were trying to kind of make it over the years and got into the neuropathic state, all of a sudden have the shock of going back and now need time to recover, recuperate, readjust, and readapt to the new normal. And that may take some time, okay? Good luck, Leslie. Case and Fox. Hi, I'm Casey Fox. Hi, Casey. I've had 2 operations. The first, all of the adenoma wasn't removed, so I've suffered spillage. Oh, I'm sorry. Now I need a 3rd operation, which means I may lose half my thyroid. And the second op affected my voice. I now sound like a guy, I think. Do you think I should go ahead or leave it be? I have no energy and weight gain. So let me explain. It all depends. So let me go through the anatomy and I'll try to give you my 2 cents on that. So this is your thyroid gland, and these are the 4 parathyroids that hang around the thyroid, right? So if you had if the first two surgeries that you did, your surgeon only looked at this side, where you had a big parathyroid, right? So if you had a parathyroid and they only looked at this side, they'd never touched this side of your neck, right? Then, and during the first surgery, they cut open the parathyroid and they had spillage of some of the parathyroid tumor cells all around, right? And during the second surgery, they went in there to clean up around here, and they took out these, but they still left some attached to the thyroid gland, and this time they're going in there and just going to remove the thyroid and clean up this whole area. Then that's okay, right? And if during that second surgery they paralyze your nerve to the voice box, so if you look at it, if someone looks at your voice box, right, called the laryngoscopy, and your vocal cord on the right side is out, then if they have to do a third surgery where they're only going into that third side, you're fine. They don't have to go to the opposite side. If they do not touch this side at all, you're golden, because the nerve to your left side that is functioning now is going to continue to function, right? So first you have to look at to go to an ENT and have them look at your voice box. If this nerve is out and the spillage is on that side, and they're only planning on doing surgery on the side where the nerve is already paralyzed, where they can't paralyze you anymore, it's paralyzed, it's gone and done. If the nerve is working, if the vocal cords are both moving, what does that mean? Let me show you. So when you look at, with a camera, they're going to go inside and look at your voice box. Your voice box is here, so the view from above looking down at your voice box, these are the two vocal cords, right? So when you speak, they come together. And when you breathe, they open up, right? If they've paralyzed your vocal cord, when they look, one side moves and this side just doesn't move, right? That's a paralyzed vocal cords. In which case you have a gap here, and when you speak, your voice becomes breathy and you run out of air when you breathe because you're leaking air out, right? And that's also an easily correctable thing, right? If you have a manly voice, all they have to do is inject fillers. You know, the fillers that we use in cosmetic surgery to fill in lines, right, in your face. If they put a filler and fatten up your vocal cord, right? If they fatten up your vocal cord, then the other vocal cord here can come and meet it, and you won't have leakage, right? But nonetheless, that's a secondary thing. If you have a paralyzed vocal cord, on the side they're going to be doing surgery, and they're not going to go to the opposite side at all, you are golden. Do that, okay? But my more important question is, do you have spillage or do you have hyperplasia, right, that they didn't see? Or do you have multiple adenomas? I just need more information to be able to figure out what is the right thing to do for you, okay? Because it's easy to just blame everything on spillage, you know, and I've seen cases of spillage. Usually when there's spillage, on the second surgery, we are very comprehensive. What that means is that we are going in and doing a lot of, we're going in there. So if you had spillage here, okay, you took, during surgery, this was cut open, and you have spillage like that, then during second surgery, what you're dealing with is you're going in and looking for multiple things. You're no longer going in and just plucking each of these one by one. No. During a second surgery, you go in and you find the nerve, right? You go stick to the capsule of the thyroid, maybe even take out the bottom part of the thyroid, go to the thymus, take the top of the thymus. You take everything out here, outside of the nerve and the blood vessels, right? Because you don't know if there's microscopic cells left behind. You don't You're not leaving room for a third surgery, right? So if you're now at a third surgery, my question to you is it that you had spillage, or is it that you have another parathyroid tumor on the same side, or the opposite side maybe, or do you have hyperplasia, right? You need to be sure before that third surgery what you're dealing with, and that requires an experienced surgeon and a lot of workup. Okay, my dear? Good luck, Casey. Let's see. Trying to see if we have more. Annette Rivetso is, I'm very grateful for your response. My final question is whether, in addition to K2 vitamin D per day, or 2,000 units of vitamin D, how much calcium should I take each day? I've never supplemented with calcium since my hyperparathyroid diet in 2000. I would say supplement with 1,200 milligrams of calcium, okay? Annette, 1,200 milligrams of calcium, 2,000 units of vitamin D, okay? Do that for 2 months and check your calcium, PTH, vitamin D, and 24-hour urine calcium. And check both vitamin Ds. And check magnesium also. I've had digestive issues, not celiac. I also have, and have also been vegetarian at times, vegan. So maybe this is all being caused from low calcium intake. It's possible, Annette. And you know, part of the problem I have with hyperparathyroidism is that most of the doctors dealing with hyperparathyroidism are not dealing with the patient. They're dealing with the disease, and if the endocrinologist says, oh, you have secondary hyperparathyroidism, go take some vitamin D and stuff, and let me see you again, right? And if it doesn't normalize, well, this is your system, this is what it is, you got to live with it. That's not adequate. That's not enough, right? And the surgeons are like, you know, NPC, you have secondary, or, you know, some of this other surgeons, you have normal calcemic, and the data says it doesn't help. Well, they're not looking at you. They're looking at a whole set of studies, not looking at the parameters that affect human beings, right? And so finding someone who's really interested in looking at you and all of you and trying to figure out how best to work with you and go back and forth till you get results. That's what you need. But thank you for responding, and thank you for sending more information. It helps me and helps the rest of the people on this talk. Anyways, moving on. Nancy Alpa-Duccini. Hi, I had a successful surgery with PTH, did not go down at time of surgery. But a couple of weeks later, did go down from 55 to 32. My blood calcium are always 10 or a little above. I'm 74. This was my second surgery since my blood calciums were always in the 10s. Surgeon feels I may have a genetic gene, even though genetic testing for low 24-hour urine calcium was negative. Okay, what do you feel I should do next? I hope I don't need a third surgery because I still do have symptoms. 2 parathyroids have now been taken out. First surgery, most abnormal taken out by general surgeon. Second surgery in August of 2025. Only taken out, and she looked no further due to dense scar tissue. Any advice? Carrie Pharmacist, did you have 4-gland expression on both surgeries? And and Nancy responds, no, neither of them were 4-gland expression, which is what I should have had. When I'm doing parathyroid surgery, I always have in the back of my mind that there may be hyperplasia going on, right? Because I have found when my parathyroid surgeries fail, right? So when I do a surgery, and during the surgery I take, let's say, 1 parathyroid out, and the PTH goes from a high number to a normal. So I consider that to be successful surgery. And lo and behold, I do labs at 1 month and 6 months after surgery. I want to look at these numbers. And I find at 1 month my numbers are lower, but at 6 months, my calcium that used to be 11.3 with a PTH of, let's say, 160, now I check it at 6 months, and now my calcium is 10.6, right? And the PTH is 90, right? This is hyperparathyroidism still. That most of the time, this is one of two scenarios, right? This is either that I had one adenoma here, which was really big and producing a lot, and a second adenoma, which was microscopic, had only a few cells. And once this one was out, this one had a chance to grow, okay? Or the more likely scenario is this situation where I have hyperplasia in the background and then had a tumor develop on top of it, right? And I take the adenoma out, right? So I take this adenoma is really overproducing, the hyperplasias can't compete and are producing very little. And once I take this out, sometime later, these start to grow and get bigger and show themselves, right? So because I've noticed this to be a more common problem, right? And this happens to 3% of my patients who have an appropriate drop during surgery. So if during surgery I don't have an appropriate drop, if it goes, let's say we start at 180 here, but it goes down, instead of going to the 40s and 30s, goes to, at 5 minutes it goes to 90, 10 minutes it goes to 70, and 15 minutes it goes to 60, right? And it's more than 50% reduction, but it's still not a lot of reduction. It still hasn't gone in the normal range. Then what I do is I do another, maybe at 45 minutes I'll check. If at 40 minutes it's now in the 40s, then I feel okay. But if it's not in the 40s, then, and if it goes back up from 60, and at 45 minutes I check it and it goes from 60 back to 90, then I suspect that there's more, and I would do a four-gland exploration, right? I just think PTH testing is so crucial in helping you figure out the more challenging cases, right? So my question that I have for you, Nancy, is, do you have hyperplasia? And you had asymmetric hyperplasia where during the first surgery they took out this one, and then during the second surgery this one grew, and they took out this one, but you still have two abnormal parathyroids in there. You always had hyperplasia. That's my concern, okay? Now, even if you're in this scenario, you can still take Sensipar, right? So what I would say is, check your labs, check your calcium, PTH, and vitamin D, okay? And if your calcium and PTH are not following a normal relationship, you obviously, and I wouldn't want a third surgery either, I understand that, right? I would try Sensipar for a while, okay? Let me get the doctor handwriting out. Sensipar. I would use that medication to see if I can bring my numbers lower and feel better. If you don't have any side effects, and the chance is less than 5% that you do, and if you do get side effects, once you stop the medication, that they reverse, right? If your numbers come lower, your calcium and PTH, and if you feel better and you're not having any problems with this medication, then you have one very good option instead of a third surgery, okay? And so if you were related to me, that's what I would do. Good luck, my dear. Rachel Kinney, thank you, Dr. Larian, for doing these live sessions. You're welcome. Do you know what would be the cause of chronically low or low and normal alkaline phosphatase before and after successful parathyroid surgery? And does it affect recovery from long-term pH osteoporosis? I'm not sure what causes low alkaline phosphatase. A low bone turnover, but there's also alkaline phosphatase in the bones. There's alkaline phosphatase in the liver, right? You need to if the low number is just a genetic base for you, where you are just producing lower than normal, then that low number may not mean anything, right? And if your bone density is getting better after surgery, okay, after surgery, and your kidney function is fine, then you're fine. The other thing you can do is you can look at your bone turnover. If you don't have osteoporosis before surgery, Rachel, right? If your bone density is normal on the bone density study, right? And your liver function is normal, that may be your particular production of alkaline phosphatase, and it may not mean anything at all, right? And I would, if you have osteoporosis, I would look at your bone turnover markers, right? And just have those numbers in view, right? And then go from there, okay? I don't think that's going to mean too much, as far as I understand it, of course. Good luck. Jill Hitchcock. I'm in the UK, so I'm not sure what time to watch. Can you clarify my situation, as I am quite confused? I think I'm normal calcium. PTH is 8.7, range of normal is 1.6 to 7.2. Magnesium was 0.91, normal. Adjusted calcium was 2.34, which is smack in the middle of normal range. And vitamin D is 125, and range is 50 to 170. So vitamin D is normal. Calcium is in the middle of normal range. Magnesium is normal. PTH is elevated, right? Phosphate is normal, and scans indicates a left lower and lower, potentially left lower parathyroid, osteoporosis in the spine. Kidney function is normal. I have severe low back pain and hip muscle pain. What's wrong with me? You have normal calcemic hyperparathyroidism with osteoporosis. I would suggest, Jill, that you have surgery. Find a good surgeon. Dr. Khan at Oxford is very good. So you may want to seek help over there. All right? Karen Robinson. I would love to know how often a failed parathyroidectomy after a 4-gland exploratory surgery with intraoperative blood testing is due to a previously unknown fifth rogue gland. Whew. It depends on your process. If you have hyperplasia, which means all 4 of your glands are abnormal, if you have an extranumerary gland, a 5th one, and it happens to be all the way down in your chest, right? During a bilateral exploration, you're still not going to see it, right? Because this one is much lower in your chest. How often that happens? Anywhere between anywhere between 3 to 20% of people have 5 or more glands. So if you have hyperplasia, there's up to a 20% chance that you may have 5 glands that are all hyperplastic. And that's why PTH testing is important, because if you do, and the truth of the matter is that when I have hyperplasia, what I try to do is I always assume there is potentially a 5th gland, right? So let's say I'm doing surgery here, and I find 1, 2, 3, 4 parathyroid glands, and they look relatively symmetric. Maybe let's say these 3 are a little bit larger, okay, and this one is the smaller of the 4. Then I would go in there and I would take out this one, this one, this one, and after biopsying that one, and check your PTH number. If your PTH numbers start at, let's say, 100, right? Range of normal being 15 to 65, right? And your PTH goes from 100 to 25 at 5 minutes, 21 and 19 at 10 and 15 minutes, then I'm fairly confident there's no fifth gland. Having said that, in this scenario, I would go on this side where I've looked at everything and I find the vocal cord nerve, and then take out everything that is not vocal cord nerve, just in case there's a fifth gland hiding in there somewhere, okay? On this side, I would limit my exploration because I don't want to, on this side, I would limit it because I don't want to cut the blood vessel feeding this one remaining parathyroid. I would look to see if in here I have a parathyroid. If I can clearly see the blood vessels coming into this parathyroid and I can identify them as being out of the way, then I would potentially go in and remove the tissue here just in case there's another parathyroid hiding in there, okay? So again, this is where expertise in your surgeon matters, right? This is a surgeon. What I'm telling you is me having done parathyroid hyperplasia surgery and have failed, right? This is the type of thing that you rarely learn from your professors in universities because these cases are not common. So if you're doing a fellowship for thyroid and parathyroid surgery for 1 year, you may not see these cases. You may see one, and that may not be enough for you to have learned. And then once you do your cases and you do a few and you fail, then you're not going to let that failure happen again, right? So that's why you need expertise in this field. This is an orphan disease, and a lot of people take interest in it, and that therein lies the problem. Okay. Cheryl Turner. Good afternoon from the UK. My question is it normal for PTs to have burning, tingling sensation on the tongue, almost like it's sore? And there's nothing on the tongue. Also, now the inside of my lips have started to feel sore. Can't get anywhere with my GP. Is it normal with hyperparathyroidism? I've seen discomfort in the mouth and burning tongue syndrome in patients who have hyperparathyroidism for two reasons. One is the valves above their stomach and throat get loose. They also have increased acid production, so acid reflux can cause these symptoms. And then second reason is, which is even more rare, is neuropathy. Your nerve is malfunctioning, so it gives you this thing. It's not common at all, but it does occur. So I would drink, Cheryl, I would drink alkaline water. I would have a diet that's low on caffeine, on tomatoes and spicy food, chocolate, mint, really bland. Go to bland diet, have alkaline water for about a month and a half. If that resolves the tongue pain, then you know it's all acid related. It's not nerve pain related, okay? Good luck with that. Leslie Harris. Oh my gosh, thank you. You're welcome, Leslie. I have some questions. I can't seem to find someone in my area that knows much about this. Understood. I had surgery to remove a 4 centimeter adenoma on one of my parathyroid glands. After my surgery, I've developed extreme neuropathy and muscle cramping, burning. This is the second person today that talks about that, specifically in my legs. Also now, in my blood work, my calcium is back up to 10.2. My sodium chloride levels are tanking. I also now have my A1C diabetic levels. I had a heart attack previous to the diagnosis. I'm so sad and at loss in what to do. I'm only 55. I've been exhausted for 2.5 years. My calcium was at 13 when I was finally diagnosed. I just don't know what to do. Well, first and foremost, let's see, you need to figure out if you still have persistent hyperparathyroidism. Calcium of 10.2 is concerning, right? But you need your calcium, PTH, and vitamin Ds to see where you stand, right? To figure out if that's what's going on. If you're, if everything is catching up with you, then I would go back to the beginning of this lecture to talk about longevity issues, mitochondrial health, and healthier existence. Because if you're feeling exhausted and you have hyperparathyroidism and you developed diabetes, that tells your body is running inefficiently, and you need to change your lifestyle and life path to put yourself on a different path, right? And everything matters. Your sleep matters, your stress level matters, your work matters, your emotional state, meaning your relationships. All of these affect everything in your body, right? If you have healthy relationships around you, your path to good health is easier. If you have unhealthy, stressful, and abusive relationships, that's a hard path to be on, right? So all of those things matter, right? But first and foremost, check calcium, PTH, and vitamin C to see if you still have hyperparathyroidism. Because if you do, then you need to treat the hyperparathyroidism first, and then go on. Good luck. I'm sorry you're in this position, my dear. MD higher. I had parathyroid surgery in 2014. Calcium has remained 10 or above with low PTH. I was tested for FHH and was positive. Okay? If I had adenoma previously, why can't have? You can. The question is, did you have an adenoma? Right? I would have to look at your numbers again, all of them. I would have to look at your calcium, PTH, vitamin D's before your first surgery, along with your 24-hour urine calcium, and the genetic testing for FHH, right? FHH is a condition where the kidney releases too much calcium in the urine, right? I'm sorry, releases too little calcium in the urine, and then the calcium backs up in your bloodstream and your calcium goes up, okay? So you have too much calcium in your blood because your kidney is not letting that go. Usually it doesn't have much symptoms. In rare cases you can have symptoms, right? But you can have that and you can get hyperparathyroidism also. You can have both conditions at the same time. It's rare, but it does happen, right? And you have, if on the surgery report, I read the pathology report and it clearly shows me that this was an adenoma, right? And there's some specific things I'd have to see on there to be convinced that you had an adenoma. Then if you had one adenoma, the chance of getting a second one's a bit higher, so it is very possible. But I would have to look at a lot of numbers to give you an answer. You need a full workup. All right, my friend? Fred Elliott. Hi, my name is Freddie Elliott. Hi, Freddie. From the UK. I was diagnosed with primary hyperparathyroidism in August of this year after having 3 to 4 years of poor mental health and overall low mood and tiredness. I'm a 19-year-old male, so young. Very young, Freddie. And I have had negative results on a sesame scan and ultrasound now. My most recent blood tests show a serum calcium of 2.9, which is elevated. PTH of 8.0, which is elevated. Vitamin D 41, which is normal, I believe. Let me see. No, it's slightly low. Vitamin D 41, slightly low. Alkaline phosphatase. I had negative results to genes associated from to hyperparathyroidism and FHH. And based on this information, my surgeon has said that I can be booked in for surgery, that I can have further imaging such as PET. I would suggest, I wouldn't even do a sesame scan. A sesame scan is just, for me, not useless, but low utility scan, right? I would have started with ultrasound, which you did, which was negative, right? And if the parathyroid is a little deeper, if you look here, this is ultrasound. You can see the ultrasound. This is skin, this is the thyroid gland, this is the parathyroid. But after this depth, the ultrasound is dark, right? So it only goes to a certain amount of depth. This is maybe from the skin to here is maybe 3 centimeters, right? So deeper parathyroid, if your parathyroid was down here, your ultrasound wouldn't show it. So I would do a 4D parathyroid CT scan, or in the UK, you can do a PET choline scan. I would do that before surgery. So do the PET choline scan. I would suggest that first, Freddie. And my parathyroid surgeon is Shad Khan. I just mentioned Dr. Khan at Oxford. Shad is really good. I would do the PET choline scan before proceeding with surgery. All right, my friend? But definitely do that. Good luck. Dr. Audrey 7737. I had parathyroid surgery 7 weeks ago. I still have a lump under the incision. Dr. Audrey, or D. Rodri. What is your question? Why do you have a lump under? I would have to look. I can't, without looking at your incision, I can't really answer you. Okay. Usually the lumps are above the incision. If you have a lump below the incision, that may be inflammation from the sutures that were used. I would see my surgeon, all right, and have them reassess it. Tritor the Brave. If all my parathyroids are the same, so what happens next? If you have hyperparathyroidism and your surgeon goes in there and finds 4 parathyroids that look all the same size and potentially normal, right? If all of them are the same size and normal looking, by normal looking I mean when you look under them, when you look at the parathyroids themselves, here's surgery. This is a normal parathyroid here. And you can see that how yellowish it looks there. Because normal parathyroids are half fat and half parathyroid, right? This is an abnormal parathyroid. It's a parathyroid adenoma. You see how brownish it looks here versus the yellow here, right? So if you go in there and you find 4 parathyroid that are yellowish, like this, okay, then you might I would suspect that you may have 4 normal parathyroids and potentially a 5th abnormal one elsewhere. So I would explore for a 5th one. That's why preoperative scanning is important, because if it shows an enlarged one here, I don't want to go and find these 4 first. I would go to that enlarged one first, okay? But if your scans are normal, you find 4 parathyroids, you then look for the 5th one. Yvonne Curtin. What happens if the nuclear scan didn't show anything? What happens next? I mean, again, as I mentioned, I would do an ultrasound, I would do a 4D parathyroid CT scan. If you're in the UK, I would do a PET choline scan. And if those are all negative and you have really high numbers or clearly abnormal numbers, then that I would suspect that you may have hyperplasia and you would have to have hyperplasia surgery. Bella Rosa 55. Why does vitamin D go down and PTH go up and calcium is low? Oh, okay. Let me show you. So, Bella Rosa is asking if your vitamin D, right, these go down, okay? Why does PTH go up? Because vitamin D tells your parathyroid gland to decrease PTH and decrease growth. Okay? So if your vitamin D is low, you don't have that, and your PTH. So if your vitamin D is low, you don't have this, and you have increased PTH production, right? But if your vitamin D is low, you also are not absorbing as much calcium from your food. So you have low calcium and you have secondary elevation in PTH, which means you have secondary hyperparathyroidism. Rusty Beth, I doubt that. What would cause PTH to remain high if abnormal glands are removed? So it's not unusual to have hyperparathyroidism, right? Let's say your calcium is 10.8, PTH is 150, right? And you have one big gland. And you have surgery and you remove it, right? During surgery, your PTH drops from 150 to, let's say, 40. Successful surgery, right? And then, this high PTH was causing calcium to leak out of your bones. You've taken the abnormal parathyroid out, right? And now the calcium in your blood is coming down, right? And your PTH lowers at first. And then your bones try to grab all the calcium from your blood. So your calcium drops too low, right? When your calcium drops too low, you produce extra PTH, right? And so the parathyroid glands that are healthy and normal fight your bones over calcium. This is a version of hungry bone syndrome. So sometimes, and it depends on how low your bone density is, this can continue on for a year. So usually when I have this scenario for my patients, I follow them up. I try to give them capsule and vitamin D and vitamin K2 supplementation along with magnesium, right? And support them and repeat testing. And sometimes it takes a year for that PTH to come down again. Bahare Hashemi, hi dear doctor, I'm 51-year-old menopausal woman with a high PTH. My blood calcium and creatinine is normal. I had osteoporosis, but after taking 4 doses of Prolia injection, turned to osteopenia. Is the surgery necessary? Baharajan, I would have to look at your calcium PTH vitamin numbers over time, and I would do a scan for you as well. If your scan shows that you have a clearly enlarged parathyroid, then you have normal calcium hyperparathyroidism, and you are falsely improving your bones with the Prolia injections, but you have the Prolia injections happening every once in a while your parathyroid gland is every day causing bone loss, right? And that's a fight that's not going to end well, right? And there's no evidence that Prolia injections, especially in the setting of hyperparathyroidism, give you a bony architecture that's healthy. It may be denser, but it may not be organized bone. It may be disorganized bone, so it may look denser on the scan, but it may still fracture because it's not well organized, right? Amin Al-Naimi, when should I expect my back pain that lasted 6 years to go away now that I tested with vitamin D18 and PTH under time? Well, if your bone pain is because of your high PTH, until you normalize it. So if you have secondary hyperparathyroidism because of low vitamin D, once you correct your vitamin D and your PTH comes down, your back pain should go away. So if your PTH goes to normal and your back pain goes away, then it was parathyroid mediated. If your PTH comes down to normal and you still have your back pain, your back pain is not related to hyperparathyroidism. It's due to some other cause. How does one correct hyperparathyroidism without medications or surgery? You cannot, right? Because hyperparathyroidism develops from a tumor, a cell getting a mutation in it, turning into a tumor, right? And this cell overworks because it thinks it's doing the right thing. It's set for a higher calcium number. There's multiple mutations in it that cause it to look for a higher calcium number, right? And it does that. And it continues to work hard, and then it starts to duplicate, and one cell becomes 2 cells, and 2 becomes 4, 4 becomes 8, 8, 16, and it grows logarithmically, right? And all of these cells have all the same mutation, right? So you can take medication to suppress it, or you can take the tumor out. There's no other way for you to reverse mutations in the same cell, right? In the millions of cells that make up a 2 millimeter tumor. So when you have a tumor that's 2 millimeters, meaning this big, that's 1 million cells. And you have to be 2 millimeters to be visible on a scan, right? 1 million cells, right? You can't change mutations in 1 million cells any other way besides either suppressing them with medication or removing the tumor, unfortunately. Hopefully in the future we'll be smarter and figure it out. It's me, KC9. Hi, my question is, what should I do if my doctor wants to wait and see if my PTH increases? My PTH is inappropriately high, but he wants to wait to make sure his scan is not negative. I had my surgery in 2021, now it's back. Find a more experienced doctor. Listen, the reason I say this is majority of times when surgeries fail, when parathyroid surgeries fail, it's because the person has hyperplasia, right? Your doctor is assuming that you have a second adenoma, right? And is waiting for this adenoma to get big enough to show up on a scan. Well, that's a possibility, but if you have hyperplasia, these three may never get large enough to show up on a scan. And if your doctor doesn't know that, right, then they're not experienced. They haven't done this enough to know this. So find another doctor. Casey, I don't know what else to tell you. Or sit with this doctor and say, hey, listen, and look at, one thing I would say, go look at your labs. Look at your labs in 2021 before surgery, after surgery, what your labs have been doing all these years. If your labs in 2021, let's say your calcium was 10.5 before surgery, and then immediately after surgery it was 9.5, and then 1 year later it's at 10, and a year later after that is 10.3, and a year after that is 10.4, then you're going to be hovering around this number, right? And your calciums are not going to go much higher than that. But you never really were normal, right? You just had a little bit of time before you got larger. This had a little bit of time, or these had a little bit of time to get large enough to show themselves, okay? So track your numbers, look at all the calcium, PTH, and vitamin D, graph them on a table, and show your doctor, right? Make a graph, make a table, and show your doctor. Say, hey, I was never cured. I just had a temporary lowering of number and then immediately started shooting off. I have persistent hyperparathyroidism, right? I'm okay with doing an ultrasound, and I am okay with getting a 4D parathyroid CT scan. I can accept the risks of exposure, right? I don't want to feel like this while we wait for this thing to be large enough where you think the numbers are where it's going to show up, okay? All right. Deborah Rogers. I'm 68 years old that was diagnosed with parathyroid problems 20 years ago. My blood calcium is always in between 10.2 and 11.3. It hovers around 10.5-ish. My PTH is always above the correct level, but it varies greatly. My vitamin D runs around 8 unless I'm on prescription supplements. As soon as I stop taking them, it tanks again. My last 2 bone scans shows osteoporosis. I failed 3 24-hour urine tests, but I've never had kidney stones. What do you mean I failed 3 24-hour? I don't know what that means. You mean your 24-hour urine calcium was really high, or was it really low? So I don't know what failed means. The biggest problems are nothing ever shows on the scans, and I've had them all. But the really big problem is my symptoms. It started with muscle aches many, many years ago. Now it's muscle and bone, and I can hardly walk. The pain is so bad I urinate an average of 40 times in 24 hours, period. I'm always highly dehydrated. I have no motivation. I have major brain fog. Every doctor I see says, yes, it's parathyroidism, but because there's nothing on scan, there's nothing we can. No, If you have hyperplasia, you'll never have a positive scan. And if you're feeling miserable and have osteoporosis, you got to find it. Deborah Rogers, please find an expert surgeon. Okay, please. You have hyperparathyroidism that is failing your body. Okay, now if your 24-hour urine calcium is a really low number, then you need a little bit of more of a workup, right? But if your 24-hour urine calcium, you may say when it failed, it's because it's too high, then don't wait. Find an expert surgeon. All right, that is done with the questions that came before. Now let's get to the questions that came during our talk. All right, let's see. Ricky Plowman, my calcium has been around 10.5 since I was a child. I'm currently 41. Should I be worried? Well, without knowing your PTH, vitamin D numbers, I really can't tell you if you have an issue or not, right? But 10.5 is concerning, so you need a full workup. I would highly suggest that you do that. Hannah Hutman, my intraoperative PTH dropped from 5.8 to 3.5 during surgery. Do you think it's only time and see and saw how calcium and PTH going? Well, it's not. I mean, let me see if you have more to your questions. Okay, so Hannah, I always have my patients check their calcium, PTH, and vitamin D with their annual exam. Every year when you see your primary doctor to do a full set of labs, check. Once you have hyperparathyroidism, you have a higher chance of getting it again. So I would check. Majority don't get it again, right? The reported incidence of getting another one is anywhere between 3 to 14%. Not dramatically high. High enough to be concerning, but not a definite thing that's going to happen. So I would just say, look at your numbers and check them every year to see if it's happening for you. All right. Ben Carlson, can Sensipar increase longevity? That's Bent, we don't know, right? We know that Sensipar brings down your PTH, so it can decrease bone loss, right? Does Sensipar allow normal physiologic up and down of PTH that's important for life and important for functioning? Does it allow your parathyroid glands to react to your body as well as they should? Probably, but we don't know. So I don't know if studies have been done to see that. How does primary hyperparathyroidism cause so much suffering from digestive tract? High calcium levels cause increased acid production, so you get acid issues. Both high calcium and PTH cause muscle weakness, right? And so your intestines don't move as well, so you get constipation and bloating. The valve muscles above your stomach get weak, so you get acid, the increased acid from calcium now refluxing in your throat. So We know the reasonings for these things happening, right? But both calcium and PTH have to normalize in order for you to feel better. Minos is asking, would you explain why parathyroid tissue is found in the thyroid gland? I'd be happy to. Let's see. It's a good question, and I would love to answer it for you. So, parathyroid glands develop when we are in our mom's bellies, in the first few weeks of life, when we form. Our head and neck are two separate pieces, like this. Or like an alien that fuses. That's why we have this line in the middle of our upper lip. That's why we have those webs in the middle of our tongue. The two sides fuse and they make these little webs, right? Anyways, on each side, the separated sides, we get these pouches that form. So first you have this big bulge on both sides. And then these bulges start forming pouches in them. And it's happening on both sides, right? And the first pouch turns into the ear, the second pouch into the tonsils in your throat, third pouch turns into the lower parathyroid and the thymus gland, and the fourth pouch turns into the upper parathyroid, right? And then they migrate down, okay? So they're migrating down. At the same time as that is happening, the back of the tongue forms a little pouch, and that pouch starts to go downward in your neck, right? And that pouch becomes the thyroid gland. So, as these are migrating down, something else in the back of the tongue is migrating down to form the thyroid, right? And as it migrates down to form the thyroid, a parathyroid may grow into it, right? May migrate here, and this thing may engulf it. This thyroid that was moving down may engulf it. Let me do a better job. It may at first do this, and over time cover it up, and the parathyroid may be in it. There's a little bit more detail to this thing. I'm grossly simplifying, but it's the fact that the thyroid and parathyroid glands, which form from entirely different things, happen to thyroid moving down, the parathyroid moving from the side, and they may merge and get into the eye. That's why that happens. Good question. Trade the stock one. Hi, I had parathyroid surgery in October of 2023, calcium 13.5, PTH 480. Now 9.5 and 40, my body crashed after surgery. All the symptoms you should have had with high calcium I had after. Well, at 13.5 and 480, you were in deep trouble. The problem is that you slowly got to 13.5 and 480, and you immediately went down from 13.5 to 9.5. That's a dramatic change, and your body had to adapt to so much change. It had adapted slowly for you to get to those high numbers, and it quickly dropped, and you had to adapt quickly to that. And that creates havoc at first, but you will feel better over time. I can now barely take a walk without my body stiffening up. I got worse after surgery, not better. Yes, but again, you're going to need time to adapt. And it can be hard. I find the people who, and I'm not saying this is what's happening with you, I find the people who were taking benzodiazepines, Ativan, Xanax, Valium before surgery, and a lot of people do because hyperparathyroidism causes so much anxiety and poor sleep and things like that. They have a harder time after surgery, and they have to detox from those medications. I try to actually have people who are on those medications stay off those medications for a month before surgery before I do it, because I know that I'm going to have a harder time after surgery to recover. So that may be one of the factors. Okay, Wanda Holmes. MEN1 here, one previous powerful surgery with 2 adenomas removed. Ooh, okay, that's a mistake. So, MEN1, 90% have hyperplasia. So if they remove 2 parathyroids, right, they did the wrong surgery. They should have taken out 3 to 3.5. And now a third with a thyroid nodule. Watching because they're small and PTH is slightly high. I'm taking D3, K2 to balance. Chronic kidney disease, no stones. What would you do differently? What can I expect going forward into a second surgery? Your second surgeon needs to be an expert and needs to go in there knowing that you have hyperplasia, looking to do a comprehensive surgery where they clear out let's say these 2 parathyroids were removed the first time around. Now your new surgeon is going to have to remove this one, leave half of that one behind, right? Leave this half where the blood vessel is coming in and going out, right? And then get underneath and clear out everything here and everything here, just in case you have more than 4 parathyroid glands hiding in these areas. So that's what your next surgeon needs to do. It needs to be very comprehensive. Why am I still getting low TSH levels after getting a parathyroid removed 2 years ago? Huh. So, TSH, thyroid stimulating hormone, is produced by the brain and is released into the bloodstream, goes to the gland, and thyroid stimulating hormone stimulates the parathyroid glands to produce hormones. If your TSH is low, that means you're producing too much thyroid hormone, right? If you're producing too much thyroid hormone, you either have a nodule that's toxic and producing too much, or you have Graves' disease, right? Is it possible that during your surgery, when your parathyroid gland was pushed to get, when your thyroid gland was pushed to get, that incidentally pushed a nodule that was overactive over the edge and got it to work more, or your immune system to be active? Yes. Did it cause the disease? No. You already had the disease, and this may have just pushed you over the edge, right? But you need a workup, all right, Catherine Ann? You need a good endocrinologist to work this up for you. Unless you're taking thyroid medications and your dose is too high. All right, Liz Womack. Hi, Dr. Larian. I had 1 parathyroid removed in 2025. My calcium is still below 9. It dropped to 7 immediately after surgery. I was cured. I am taking Berry Melt calcium. I've decreased dosage and get labs December 22nd to see if my calcium is in normal range. Is this normal after parathyroid surgery? Well, it's hard to answer without looking at your calcium, PTH, and vitamin D now, right? So let me explain. If you had a surgery when they removed 1 parathyroid, right, and only went to here, they didn't go looking, they didn't do a 4-gland exploration, which means they didn't potentially damage there's other 3 glands. They only took this one, right? And so the surgery where you had this only, and your calcium, let's say, before surgery was 10.5, and after surgery is 8 point, it's from 7 to 8.8, right? And despite having these numbers, you don't have the symptoms of low calcium. You don't have tingling in your in both fingertips or around your lips. And your 24-hour urine calcium is normal, then maybe your ideal calcium numbers are in this range and you don't have to worry about it, right? So that's why your PTH and vitamin D matter, because if your calcium is 8.8 and your PTH is 30, and your 24-hour urine calcium is, let's say, 100 or in the normal range, then this is your normal. You're fine. You don't need to do anything else. On the other hand, if your calcium numbers are this low and your PTHs are really high, 150, then you have a malabsorption issue that you need to deal with. Right, which is less likely because you probably would have had malabsorption before surgery too. On the other hand, if you had bilateral exploration and you went from 10.5 to 7 to 8.8, right, and you check your PTH and your PTH is 5, that means your other 3 glands are not really working well, right? That means during your bilateral exploration, they damage your other 3 glands, and you now have hypoparathyroidism, right? In which case, what you need to do is to take high doses of calcium, and you need to take rocalcitrol, which is activated vitamin D, because without PTH, you can't make activated vitamin D. So your other labs, Liz, matters. So look at your other labs before making any decision. I can't tell you anything without looking at your other labs. Good luck, my dear. All right. Linda Louise 1. Hi, Dr. Larian. I'm all the way on the East Coast in New England. If I had a way, I'd coming to get help from you. I think you're amazing. You're too kind. I have both thyroid and parathyroid issues. To continue my nephrology, my diagnosis from secondary to primary. I have trouble swallowing, I have chronic laryngitis and raspy voice. That usually happens from acid reflux from hyperparathyroidism. I'm 65 and feel desperate. I have almost every symptoms. My PTH level went from in the 130s down to the 70s last check. Your PTH can go up and down if you have hyperparathyroidism. 70s is still abnormal. Vitamin D is into high 20s. Calcium is always normal. I had another kidney stone removed this past. Listen. I see that you're in trouble, my dear, and I think you obviously need to be addressed, right? Based on what you're telling me, I still don't know if you have primary or secondary. And I'm not saying your nephrologist doesn't know what they're talking about. I just need more numbers, right? The first thing they teach us in medical school is don't trust your mother, meaning even if some expert tells you something is happening, re-examine it yourself, right? Don't trust your mother doesn't sound right at all. But don't trust any doctor, not because they're misleading you, because they may be mistaken, right? There are times that I see a patient for years and years and I think they have one thing going on. And at some point I'm stumped and I'll just say, hey, get this other doctor to look at you because it will be a fresh set of eyes and they may see something that I just have chronically overlooked for you, okay? Right? That doesn't mean I'm a bad doctor. It means that I'm just human, right? So you need a fresh set of eyes looking at your numbers. And I'm happy to do it. You don't have to come here. I can remotely look at your numbers for you, okay? But I need more information to be able to tell you if you have primary or secondary, okay? But if a nephrologist is right, let's say, and I look at your labs or someone else looks at it and confirms you have primary hyperparathyroidism, even if you have normal calcium hyperparathyroidism in the setting of kidney problem, right, and kidney stones and a lot of symptoms, I still would suggest that you have surgery to address it. All right, my dear? Good luck. I'm here for you if you need me. Mandy Thecker. Have been dismissed for many years that a high calcium is secondary to lithium. Okay? Finally got someone willing to look at it further. Well, high calcium due to lithium is because lithium causes hyperplasia. And hyperplasia, parathyroid hyperplasia, causes hypercalcemia and hyperparathyroidism. Had a 5 centimeter right inferior adenoma removed and right superior enlarged adenoma in May. Surgeon felt 95% sure this was a problem and due to difficult neck didn't explore further. Figures not improved post-surgery, commenced on cynic acid to try to improve some symptoms. Had PET scan which relieved a 5th enlarged gland. Then they reviewed all previous scans and identified possible other adenoma on the left side. My thyroid lies behind my collarbone, hence difficult access. I'm lined up for surgery in January to remove the 5th abnormal gland and testing before moving on to the left ones. Also doing my gallbladder at the same time, bit concerned about my difficult anatomy. Mandy, people who have lithium-induced hyperparathyroidism generally get hyperplasia, right? So they may get really large glands that look like adenomas, but be hyperplasia. They can get adenomas, but generally speaking, they have hyperplasia. So your surgeon should leave one or half of one gland intact and remove all other parathyroids. So if they think you have a 5th gland, they took out 2 glands, then this surgery should remove at least 2 or 2 1/3 parathyroids for you. All right? And doing a gallbladder, I mean, I like doing 2 processes at the same time, but if you've been on lithium for a long time, you have a lot of issues going on, right? You may not want to tax your body so much in one surgery, but really good luck, my dear. Casey Miller, 28-year-old female, had primary hyperparathyroidism in 2021, had my right lower removed, now symptoms are coming back, calcium 10.8, PTH of 55. My surgeon wants to watch it and see if PTH, no, you don't need to wait for your PTH to increase. Normal parathyroid glands, right? If let's say the screen is the range of normal. In a normal parathyroid environment, when your calcium goes up, your PTH goes down. When your calcium goes down, your PTH goes up. So this is what's been going on. You have a calcium that is way high, above the normal range, right? And your PTH that's here, right? What is he waiting for that? You're already abnormal. This is not a normal parathyroid function, right? Which tells me you need another surgeon. You need a more experienced surgeon. That's all, Casey. Good luck. All right. Let's see if there are any more questions. Allison Bell, pieces of my teeth have been falling out in varying sizes. Will this stop after my surgery? I've been diagnosed with primary hyperparathyroidism with hyperplasia. I have seen tooth issues. I've seen more jaw issues than tooth issues, but I have seen tooth issues, and it doesn't happen often, right? But when it does, it usually does. It's not immediate, but it does improve over time. So hopefully that'll be the case for you, Allison, as well. Carmel Gummit, Kemp. There is no choline being manufactured in the UK currently. I'm waiting on a PET choline scan. Oh my God. So the problem with the PET choline scan is that the 18-fluorocholine radioactive tracer has a very short half-life. So they have to make it and use it right away. And so if you're not able to create it on a regular basis, you can't do the PET choline scans. But I am a huge fan of the 4D parathyroid CT scan, all right? And so if you If you haven't done that, Carmel, I highly suggest to do that while you wait for the PET choline. And if you've already done every other scan, then you have no choice but to wait. And the last question that has come in, melanistic marble. Oh, Ferry Elliott. Shad Khan was my surgeon for both of my surgery. He has done an ultrasound himself. He may be able to see the culprit. 4D CT is also an option in the UK. Good luck. Thank you, melanistic marble. Good luck to all of you. That is all for today, and that is all for 2025. This godforsaken year is behind us. Hopefully next year we'll have a better year. All of us will have better leaders everywhere in the goddamn world. We have a new set of politicians coming in everywhere in the world that care for us more than money and more than big business and more than power and control and everything else. I wish you all the best. I wish you all love, friendship, joy, health, and I hope to see you again next year. Thank you for coming in, asking questions, challenging me, and making me think. Thank you, thank you, thank you. Be well.